Good afternoon. I'm Jeff Selberg from the Institute for Healthcare Improvement, and my partner Kathy Luther, also from the IHI, are going to spend about the next hour with you to address a topic that we've heard about through the entire forum. Now, we have a long title, so long I have to read it. It says, Achieving More with Less, How Effective Leadership and Quality Improvement Can Reduce Costs. So Kathy and I approached this topic with great enthusiasm, worked out our design, and figured out that we had a 3-day seminar. So we realized that we had to cut back and we had to find a special point of entry. And so what we decided is that we would talk about this concept of disruptive innovation and how it impacts improvement in innovation. So when you think about leadership, you think about these 4 leadership questions, because leadership is about building capacity to achieve results and to achieve those results themselves. So what I'd like you to do is look at those questions and ask yourself, how good are you? Do you know where you stand relative to the best? Do you know where variation in what you're responsible for exists? And do you know your rate of improvement? Now, there's a hidden question in these slides, and it is, for what? Is it for central line infection rates? Is it for premature mortality in your hospital? Is it about the functional outcomes that you're trying to achieve for total joint replacement? Is it about achieving a higher level of health for frail elderly? You can ask these 4 questions for any one of those. And as a leader, you need to be clear in terms of what it is you're addressing and how you move forward with these 4 questions. There's another set of beliefs in terms of leadership. These beliefs come from a person by the name of Doug Bonnicum. Doug is the patient safety officer for Kaiser Permanente in the United States. And he was formerly the safety officer for the submarine corps for the U.S. Navy. A good person to have as your safety officer. And Doug has studied leadership in the military and also in the private sector, and he comes up with these 5 beliefs. The most important one is, where do you place your attention? Where do you focus? An acknowledgement that if you are going to have your leadership felt, it can be risky and difficult. Articulating a vision, especially if you want a commitment to that vision and creating a shared vision, needs to happen with listening dialogue and a diagnostic as to where your team is and what they're capable of. And most importantly, you need to be thinking about your own failures and how you learn from those failures. There's a real sense of vulnerability in that, but that's where the learning comes from, transparency. And lastly, this concept of appreciative inquiry, where rather than telling, maybe asking leads to the learning. So a couple of points about leadership. Where I want to go now is this concept of disruptive innovation. This is Jason Wang. He's one of the co-authors with Clayton Christensen for the Innovator's Prescription, which I believe came out in 2007. And this is his concept of disruptive innovation. Now, this looks like the solar system, but actually what it is the outer ring is all of us. And that inner center ring is where the experts live. So when we were thinking about calculating things about 40 years ago, we used something called the slide rule. Some of you remember this. When I tell this story, I have people actually in a room who never heard the term slide rule. But then it was replaced by something called the mainframe, and then a mid-sized computer, and then a desktop, and then a laptop, and then finally a smartphone. Now, the diagram is put together in such a way that you can see that the original technology required expertise. There were only about 5 people in the United States at the time the mainframe was invented that knew how to run it. But over time, we all know how to use a smartphone. Billions of us know how to use a smartphone. Now, in the course of this disruptive innovation, there was an organization that was in Boston, Massachusetts called the Digital Equipment Corporation, DEC. 1984, they were the leading computer manufacturer in the world. The world, leading. By 1990, they didn't exist. In 1984, as they were the leader in the world, their CEO said, "There's no place in the home for a computer." And they went away. In some of the studies about DEC, it wasn't just about absence of vision, it was also about their framework. They were used to working with highly technical people. And they took great pride in the technical aspects of the machines that they built. They were never able to make the jump to what we would call a retail market in working with the likes of us. Well, how does that apply to healthcare? Well, the inner circle, if you think about healthcare over the past 50 years, has been occupied by the academic medical center. Because experts are very expensive, and there aren't very many of them, so we have to concentrate them. But over time, look at what has happened. The same thing for certain things in healthcare has gone back out into the outer ring, with what we'll call less expert people knowing how to do what only experts knew how to do just a short time ago. How far is this disruptive flow going to go? Are there things now that lie in the hands of the experts that in fact a patient could do next year or next decade? We believe that this type of disruption is a key to the reduction of costs and the improvement of quality in health and healthcare. Now, I want to talk about the concept of life cycles, product life cycles. So what we have here in this diagram is on the vertical axis is a term called viability. It's a euphemism. The higher you are on this chart, the more viable you are. The more viable the product, more viable the organization. Across the horizontal axis are terms. There's clinical model, there's business model, and there's infrastructure. So in this first curve, we're outlining something in a clinical model called episodic care. We heard a lot about that over the last couple of days. A predominant business model of fee-for-service and an infrastructure that's segmented, because it can be. You go to one place for one service, they support you, that infrastructure supports you and the provider. And then when you go to another place, we'll take the health record, for example, it's separate from the first place. Now, the second curve suggests perhaps there's a new clinical model which we'll call coordinated care, but it requires a new business model really to be viable, to really spread and scale. And we'll call that bundled payment or prepayment or capitation. And it also requires a different infrastructure, and we'll call that an integrated infrastructure. And last curve, the third curve, we'll call patient-directed population-based, connecting health and healthcare. And Kathy and I don't really have a business model for it. We'll just call it disruptive innovation. Maybe one of you will coin a term for it. And we'll say that the infrastructure is the cloud technology that already exists. So when you look at this, you're probably wondering, well, what does this have to do with me? And do I really understand it? So let me use another non-healthcare analogy. Let's say that first curve is the Sony Walkman. You remember that? It was a tape. It was bulky. You could grab it with one hand, you could hook it on your waist, and if you were pretty strong, you might even try to jog with it. And let's say the second curve is the Sony Discman. Better sound, you could sequence the songs on it, had a little problem with the disc skip. And let's call the third curve this. This is an Ipod Nano. It's multifunctional. It's a clock. It's a radio. It's my music library. It's my podcasts. I can downstream songs to my computer and to my iPod. Now, how many of you have a Walkman? How many of you have a Discman? They ceased to exist. In other words, they peaked and they hit that dotted line and they passed the inflection point, that solid dot. And then they ceased to exist because there was a disruptive technology that took its place. Now, interesting, Steve Jobs, in terms of that third curve with regard to the iPod, had to invent the business model. Originally, the music companies did not want to deal with him. They felt they were going to lose revenue. But there were so many acts of piracy in terms of the intellectual property, he was able to find a way. And even though Sony had all three components, they had the operating system, they had the brand, and they owned the music company, they were so divisionalized, they were incapable of inventing the iPod, even though they had the three pieces. So the question, I think, for us in healthcare is, are we Sony? Are we Apple? Are we integrated? Where are we in terms of this model life cycle? Now I'm going to ask Kathy to come up now and give you some very specific examples of what we call first curve, second curve, and third curve interventions and improvements. Kathy?
So as you can see, I like pictures versus graphics. But we start to think about this as the first curve episodic tends to occur within the walls of a hospital. The second curve coordinated care tends to occur right outside those walls with people coming in or going out of hospitals. The next curve, where we are just starting to think about how to go, begins with patient-directed care. What do they really want? Can we deliver it? We've been talking about this for years and years and years and are just now beginning to have some real breakthroughs in what that could look like. And finally, the population. What does the community need? What does the city need? What does this neighborhood need? Does it need these four walls? Is it missing the connections in between, and how do we think about that? You all come from a variety of settings. Some of you are within the walls of a hospital, some of you are working in coordinated care, and some of you are working very much in the community, starting to build your healthcare system from there. You can start working left to right, or you can start working this right to left. But you need to be thinking about all four components as you're beginning to do this. We're going to talk about the disruption now, and the disruption that we're thinking about is we're calling waste. And that's somewhat abhorrent to some people who work in healthcare. We think everything we do adds value and is terrific. If you talk to some people, and physicians in particular, they'll say, this gets in my way, that gets in my way, patients get in my way. These are things patients talk about. We saw earlier the waiting room, where we batch patients and let them sit there for hours and hours. And what are the things that are waste? Poor coordination leads to readmissions. The interesting thing about this is waste in one sector often begins in another sector. So readmissions, waste in coordinating care often begins in poor planning in the hospital. Lack of community organization, which you heard about from Maureen in her keynote, really can lead to poor health, which leads to waste in the other sectors. Each one is very specific to your organization, and you heard Maureen take it all the way down to a specific zip code or a specific small geographic area and what that begins to look like. We're going to get right into the level of a hospital, but I'll show you what this sounds like. This is Dr. Alan Morris, who is a physician at Intermountain Health System in Salt Lake City, Utah. He began this many years ago, and I will say he began it with a support network around him that was willing to grow with him and to support him. His early work was around interventional guidelines in an ICU on a ventilator. He found that there were about 75 variations among only 16 to 17 physicians in how they treated a ventilator. He could not even begin to think about how to standardize that, much less get a clinical guideline, until they began to think about how to do this and build the order sets. This is from the ground up at Disruptive Innovation. Now we say, we sit in a room, we make an order set, we send it out, sometimes we load it in a computer and say, this is the way we're going to do it. This was very disruptive as it began at the bedside, at the patient level, as they were thinking about how to do this. Interestingly, in a group of very acutely ill patients over time, the rate of variances when they got the guideline together went from about 60% down to about 6%. And they approach this as there should be some variation, because the guideline will not be one size fits all. And if you vary from the guideline, let me know why, so I can understand how to improve, or so we can see if there's an emerging population, or if there's new things that we can begin to learn. The survival rates decreased dramatically, as you can see, and physicians who thought it was going to take much more time really got time back in their day because this work, which is very tedious, was managed for them. Obviously, reducing variation is a hallmark of Deming's work. He also said variation is the enemy. But we really need to focus on process variation, not necessarily provider variation. When Dr. Morris began his work, he was thinking about it as a physician by physician, but what he really found is that there were multiple processes within the work that were changing over time. So this is what happens in the first curve, episodic defects, as we start to think about within the walls of the hospital, as we say. And these can be any of the things that you're thinking about or you're working on in your organizations. We've heard a lot about them today. Overuse, flow delays, end-of-life care. The interesting thing about this is, speaking of disruptive innovation, I've now been in organizations that have wiped out CLABSI infections, have wiped out ventilator-associated pneumonias, and are seeing big changes in the way they do work. 2 or 3 or 4 years ago, we would have thought that was completely impossible. And in a former organization, when I actually said, why don't we just see if we can prevent these, they said, well, you can't prevent them. That's just what happens when you put a patient on a ventilator. We now know differently. We also know that that is a huge waste in our systems, a huge cost to the patients, a huge cost to the hospital system. And just average for a 350-bed hospital, we did some calculations through our research at IHI, we really think if they could just get to 50% of the best, get in the middle, that it would save between 2.5 and 5.5 million a year. This is what we talk about as we think about taking waste out of the system and beginning to disrupt our innovations. I was actually at an organization about 2 weeks ago where it's a big academic medical center. They have taken their infection rates to very low levels. They've had 0 infections in many of their ICUs for years. They were having a discussion about how are we going to make sure, if we have a ventilator-associated pneumonia, that a resident will get to see one. So they wanted a system now to show the deviation from the norm, because the norm now is 0. The second curve we talk about is what is coordination defects. We talk about coordination of care very often, but we don't really have the systems that support that coordination, like Jeff talked about, with not only patients but healthcare providers having access to information, knowing what the next step should be, having a longitudinal plan for patient care, not just they're outside my walls and they're somebody else's problem now. How do we begin to do that? These are some of the things that are coordination defects. We tend to think about some small things, but some of them are very large. Which patients are admitted that should not be? Why does that happen? Do we have competing measures within our facilities? Is the emergency room measured on their time to admit? And so it's very easy for them to send a patient to a floor that maybe they could have worked with a little more, and maybe we could have found a better setting. And we don't really have linked organizations that can really help and support in that level of care. The other thing we like to think about is safe landing spaces, and you'll hear this from your physicians and your clinicians. They will say, I could send this patient home if. I wouldn't need to admit this patient if. And what they're saying is they don't have confidence in a safe landing spot for the patient to be. And that's when we as healthcare leaders need to be listening very carefully and thinking about how do we build that safe landing spot, because that is taking up time and utilization and beds that don't need to be. We're going to talk about focusing on the patient and now talking about care, what we call end-to-end, beginning to end. Some of you may be aware of Dr. Tony DeGioia's work. He is an orthopedic surgeon at the University of Pittsburgh Medical Center. He's actually an engineer by training who went on to medical school. The interesting thing is he started thinking about what did his patients need. He does a lot of total hips and total knee replacements. He designed care based on his patient population, what they needed, and what he needed as a surgeon to provide good care end to end for his patients. He talked about education. He actually had shadowers follow patients around, follow them all the way home, ask what they needed, see where things were located. He worked with anesthesia to develop not only less invasive techniques, but really good pain management. Rapid rehab protocols. His patients are actually up and rehabbing on the same day they have their joint replacement done. He really created a team that has a collaborative culture and a learning environment. So they learn together from each patient and they start to see how they can begin to move this more easily and more swiftly, and a sense of community among the caregivers and the patients themselves and his own team. And he talks about wellness rather than sickness. So he talks about this as, this will get you back to a health state. We're going to get you up very quickly. We're going to manage your pain. His results are fairly impressive. 0 mortality rate. We wouldn't probably expect a mortality rate in this patient population. His infection rates are very low. He's had 0 dislocations, very high compliance with his antibiotics. 95% of his patients are discharged home within about 3 days without any handheld device to assist them. 99% of his patients have reported that their pain was well controlled because the pain control begins before the surgery. His patient satisfaction scores are very high, and his length of stay is fairly low. Some cases 40 to 50% below the national average. And people don't believe this, but I've actually seen it, and he can do himself 8 joint replacements before 2 p.m. during a day because he has a system that supports him in doing that. And yes, he does use 2 rooms. But he thought about this as a patient-directed way. What are my goals? What are my life? And what is my health? And actually, he thought of it as himself. His goals were to not be tied up all day in the operating room. His goals were to have a life where he could be home with his children as they were teenagers, and he wanted his own health to not suffer as he was taking care of more and more patients. And he brought that mentality to what he was doing with his patients. So what is it that patients want versus what is it that we get paid for? And mostly we make decisions about how can we get paid and what's the business model and how does this go. We need to begin to link more closely, as I've said before, with organizations. And we're also starting to learn, which some of you from the low and middle income countries know very well, and we can learn from you. We've sort of negated the whole community. What is in the community and what are the resources there that can bring to bear on the situations that we need? And how can we begin self-care with coaches? Diabetes, we heard about Christian who started to do his own dialysis, and what does that look like for patients with heart failure and others, and how do we do that? And finally, the last is population-based, and that's what we're thinking about as the triple aim, and we've been talking about that a lot. But that's really about the community. What does this community that we are in right now, where our organizations are, where we live, what are the specific needs of those people? And it's usually not immediately a hip or a knee replacement. It's often something much more basic and in the community about exercise centers, obesity, chronic conditions. What are those things that don't even hit our doors in a hospital, but when they do, they become very problematic? And then who are the employers and the industries and folks that we could actually work with that maybe we haven't even touched base with before that? The other thing we're working with is what we're calling our hidden populations, and I'll talk about this a little bit. We tend to sort patients by their diagnosis, and in the US we use a DRG system, and it's really constructed as a financial payment model. The interesting thing is that I've worked with often financial people, and they think the DRG system was constructed by clinicians. And if you're talking to clinicians, they don't see any clinical value in this system. The interesting thing is patients have to have a 1-to-1 ratio, so they have to be assigned to something no matter what. Well, the interesting thing is patients don't come with very nice, neat illnesses. They come with multiple other things. They come with comorbid diagnoses. They come with social problems. They come as frail elderly, perhaps for surgery, perhaps for something else. So they come with behavioral and substance abuse. So the thing is to be thinking about patients in different groupings and what does that look like and what is that doing to your system. The interesting thing we found out is that we were working with an organization who looked at their readmissions, and they found out that a high percentage of the readmissions were elderly people that had a low hemoglobin. They would have never found that by looking at a DRG, but they began to look at their patients in very different ways, along with their comorbid conditions, to begin to uncover that very differently. This next thing I want to talk about is what we call the visibility of these hidden populations. In the community, these things are very visible. Mental stability, obesity, most of these things are very visible within the community. Education levels, nutrition, access to good food, access to walking trails and exercise. As you move forward and you get into the hospital, it becomes more and more hidden because of the constructs of which the healthcare system as we know it operates around a diagnosis and a medical model. And these are some of the things we're beginning to think about as we think about this continuum. The interesting thing, we were working with KP, Kaiser Permanente in California, and one of their models they were looking at is community-acquired pneumonia. And they were able to actually look at their patients across the whole continuum. The interesting thing they found when we talk about coordination is they found that patients admitted to the hospital, not that needed to go to the ICU, but needed a few days on a med-surg unit, admitted from the emergency room, they had made at least 3 contacts with the healthcare system prior to that. They had called a physician, they had gone to an emergency room, they had gone to an urgent care center. They had tried something, and their needs were not met until the situation required an admission. So it's a very interesting way to begin to think about what is in the community, what is patient-directed, and when they're beginning to direct their care, how do we support them in that? And how do we listen more closely to what they are, and how do we anticipate where this is going to go, and how do we begin to support them? So what's the key to jumping a curve? Obviously, there are clinical disruptors to jumping a curve. But the other thing is, as we go into this world of finance, we need to have financial and clinical partnerships. Financial folks think in terms of spreadsheets, averages, aggregate numbers, those sorts of things, DRGs, averages, means. They think about service line and payer classes. When you talk to clinicians, they think about the patient's chart, whether it's electronic or paper or wherever it is. They think about their patients one at a time. Oh, there's so many patients, this is what I have to do. They also think about the worst case. If you've ever talked to a clinician and say, we'd like to try something else, self-dialysis, oh, they couldn't possibly do it. Because what's the next story? It's the worst case of the very worst patient. We don't think about the lead patient, the Christian, who could actually do this. We don't think about the 80% that we could actually standardize, so we have room for the 20%. And they think about, obviously, complicating factors and social factors. And they tend to say, in huge generalizations, everybody has this, and everybody can't do this, and nobody, so this won't work. You need to get those people together to start to speak the same language and start to craft the patients and describe them in the same ways, so that you can begin to move forward with a model that not only meets the clinical needs of the patient, but can be financially viable as well as you're thinking across the continuum. And with that, I will just close as we're understanding the key to moving this is to really understand the continuum. Some of you have the entire thing and you've got your arms around it all. Some of you only have one space to start. Some of you are linking with 2. As you begin to do that, always be thinking as you're disrupting what's outside and where am I going to go next and how will we manage this going forward. Jeff.
Thanks, Kathy. See if my mic, there I am. The thing I love about working with Kathy is I can afford to be up in the clouds and ethereal because she'll bring the presentation down to the real, factual elements. I hope these examples put into play some of the concepts. So I want to have a little fun now in terms of this third curve, what we'll call the new or the next paradigm. And this is a simple chart that Enrique Ruelas put together. He's a senior fellow with IHI. He was vice minister for the Ministry of Mexico. And he talks about from to in terms of disease-based to health-based, cure to prevention, physicians and nurses to multidisciplinary teams, and we can go right down the list there. And then you see things like from standardized to personalized, patient to provider, provider at a distance, patient to person. How do these things integrate? How could you have a provider at a distance and it still be personalized, for example? Well, this next person is John Moore. John Moore is a unique person. He graduated from medical school. He went into an ophthalmology residency, and after a few years he decided he didn't want to be a practicing physician anymore. And the reason he didn't want to be a practicing physician anymore is that he felt that the relationship that he was having with patients was paternalistic. He hated the relationship. So he went to the Massachusetts Institute of Technology Creative Media Lab and started developing technology to create and help patients build their fluency in terms of their chronic diseases. Now, like any disruptor, John feels very strongly about his approach. So let me read you what he says. The doctor-patient relationship is deteriorating. Today's information technology solutions are exacerbating the problem by perpetuating a paternalistic decision-making and episodic care. His not-for-profit organization, Collaborhythm, is a technology platform that enables a new paradigm of healthcare delivery, one where patients are empowered to become active participants and where doctors and other health professionals are transformed into real-time coaches. And John believes that this radical shift in thinking is necessary to dramatically reduce healthcare costs, increase quality, and improve health outcomes. John is a disruptor. John doesn't believe in an expert culture. He believes in blowing it up. He believes in creating the devices, the ways for patients to care for themselves. Is that really possible? Well, let's talk about this cloud infrastructure and what we'll call the patient's health record. Now, typically, we would think about information from hospitals, but we would also think about other healthcare organizations where we can integrate all that information. But what about fitness center? What about home telemetry? I read an article here just a few weeks ago that said probably within a decade, chips are going to cost less than €1, less than $1, maybe even less than a dime, which means that everything can be smart. What's the impact of that in terms of biometric monitoring? And what about financial services in the grocery store? What about if we had a health record in this, an iPhone? It's the patient's record. And what if not only did we have data in this record, but it was smart? It was smart about the person that the record is for. And what in medicine now can be moved from what we'll call intuitive trial and error, problem solving, moving it to probabilistic pattern recognition, and then what Jason Wang and Clayton Christensen have coined as rules-based or precision medicine. How much of the record can be utilized using algorithms that are smart? Smart for the person. And what does that do in terms of the third curve? Now, I've given this talk many times, and I'll have lots of people come up to me afterwards and say, I can't get my patient to adhere to the medication protocol that I have them on now. This makes no sense to me. And my response is, how are you helping them adhere? What are the tools that they can use to adhere? John Moore has a dream, and it's a dream that he's pursuing. That third curve. Now, I want to go back to leadership here for a moment, and I'm assuming that all of you are leading organizations or parts of organizations. And so, what do we talk about when we're thinking about that first curve? All the things Kathy talked about so well in terms of reduction of hospital-acquired infections, for example. I would call that optimizing the current model. Very important. You can't just jump to the second curve and leave the first curve alone. So what are the things that you are doing to optimize your current model? And we'll call that technical leadership because you know how to do it. You've done it before, your team's done it before. It's just a matter of time and doing what you know to do. But what about jumping that curve, that oval? Being in a place that you haven't been before. You're transforming an organization, and all of a sudden, you've got to learn your way through it. We'll call it adaptive leadership. And so you're looking at things like new beliefs and behaviors, you're looking at new relationships, you're looking at a new value framework, something you haven't done before. And probably because you haven't done it before, you're reluctant to do it. Because after all, you're responsible for maintaining the organization that you're stewarding. You're responsible for maintaining, creating, if you will, a bureaucracy to assure that the systems that exist work. Because after all, every system is designed, perfectly designed, to achieve the results that it gets. So if you're not changing the system, it's probably a little silly to think you're going to get different results. How do you transform your system? So some do jump the curves, some succeed, and some fail. And while I love this chart, it's symmetrical, it's pretty, it has one problem. It's wrong. Because the real chart looks like this. The real chart looking forward is, a lot of you don't know if that second curve is ever going to happen, much less the third one. And while we think that there's a synchronous approach in terms of the clinical model and the business model and the infrastructure all moving together in perfect harmony, we all know that they don't. There will be clinicians that say, we have the new way. Intermountain, Alan Morris, we have the new way. We improve survival rates, we reduce costs. But guess what? In that system, they also reduce their revenue. The business model was not supporting that new clinical model. Intermountain, because of their mission, did it anyway. But how often do they do that until they start thinking about, are we viable? How do they move not only their clinical model, but also the business model when they don't have full control over that business model? And how does the payer say, you know, I think bundled payment and capitation is the way to go, but it will require billions of dollars of infrastructure investment to be able to do it effectively, and only 5% of the providers that I contract with know how to do coordinated care. How does this happen? And then when you look at the third curve, patient-directed, population-based care with no business model that exists, really? How do you manage all of this as a leader? Well, as we think about all of those uncertainties, there's another piece of this puzzle. Fortunately, there's another piece. And it's the solution piece, in my estimation. It's the cornerstone. Because, believe it or not, I think the patients are the true disruptors. And here's a couple of examples. And actually, it's great to have this machine here so I can tell this next story. Gilbert Salinas, a paraplegic, shot himself when he was 18 years old, paralyzed himself from the waist down. bound to a wheelchair. He told a story to about 300 providers who were responsible for his care about the fact that he got a flat tire on his wheelchair. It took 3 weeks to replace it. Now, we may hear a story that it will take seconds to replace this tire. What happened? Well, there's durable medical equipment, there's requisitions, there's reimbursements. All sorts of things stood in the way. But then he told a more compelling story, and that more compelling story was the fact that he needs to catheterize himself to void. And he was limited to 17 catheters a month. And he told the story about the fact that he had to reuse the catheters, and he had to clean the catheters, and he had to do this in a public place because he's employed. And he uses public restrooms like the rest of us. And inevitably, he didn't clean the catheters particularly well. It's a little humiliating to be washing out a catheter in a sink amidst people coming and going. And as a result, he was continually on Cipro, and he was admitted at least once, if not twice a year, for urinary tract infections. And his comment was, his question to the 300 people who were responsible for him was, why don't I just get more catheters? You're paying more money by admitting me expensive antibiotics. He just asked the question in an appreciative way. And after the session was over, there must have been 30 people who literally rushed the stage to solve the problem. And that was the culture of that organization. And you could say, well, it was the culture of the organization. Why did he have the problem in the first place? Because this was the first time this organization brought the patient into the room for a leadership meeting. And my belief is that the physician executive, the administrative executive, anyone could have told that story, but wouldn't have had the impact that Gilbert had. The patient is the disruptor. And we've already heard about Christian in terms of dialyzing himself. And there is a great story in Christian in terms of dialyzing himself, and Maureen told that story yesterday. But for me, the real story is how he transformed that dialysis center. As Maureen said, before all of this transformation occurred, they weren't exercising. They were curled up. They weren't thinking about that next life opportunity. And they are now. And that's the real transformation. So I think when we look at these model life cycles and these curves and these concepts, there is a constant. And the constant is the patient. And while there's uncertainty in terms of clinical models and there's uncertainty in terms of the business models and infrastructure, there is not uncertainty in terms of what we're responsible for. And that is meeting the needs of the people we care for. And so, I want to end by a few quotes from an article in the Harvard Business Review in 2010, Nonaka and Taiuchi, The Wise Leader. I ran a 3-hospital system for about 13 years and another 2-hospital system 12 years before that. And I always felt that the key to leadership was to know everything and make sure that everybody believed that I knew everything. That might work in terms of a first curve intervention, although even that's doubtful. But it certainly won't work if I'm ever going to lead an organization to jump the curve. And there's vulnerability in it. The decisions that will be made, that I've made, I'll make them again and again, and they'll probably be reversed. There will be misunderstandings because you're developing new relationships. There will be inconsistency. And inside every solution, you'll have more problems. And believe it or not, most of the time, you'll feel like things are totally out of control. Because what you're trying to do in this, as you jump the curve, is to manage the disruption, channel it into innovation, into improvement, in transforming your organization. I think these two said it very well when you think about, you mean you're telling me that I have to be on all three curves to really serve my community? And the answer is yes, because what you need to be is a servant of what is, incrementally improving what is, serving your community, serving your staff, serving the patient, serving the person, and then also at the same time being the shaper of what might be in terms of that second and third curve. It's been a pleasure. Kathy and I thank you very, very much. Do we have any time for questions? I think we might, if anyone would like to ask us anything. Okay, thanks again.